Hello my dear friends. So as a part of the continuation of the ECG series, in this session we will discuss some clinical based ECGs. So if you take the first one, I have a patient who is 35-year-old male. He is type 1 diabetic and he presents feeling generally unwell with abdominal pain and as well as dyspnea. And ECG is shown here. What is the diagnosis? The options are acute inferior wall MI, hyperkalemia, digoxin toxicity, and then hypokalemia. So if you take the ECG here, you are able to make out that there is presence of tall tented T waves. Right? There is presence of tall tented T waves. So the presence of this particular tall tented T waves, what is this suggestive of? This is suggestive of the hyperkalemia. Now, the tall T waves can appear in two clinical conditions. Number one, in hyperkalemia, you will have tall T waves, right? And you will also have tall T waves in case of acute myocardial infarction, right? That is in case of acute myocardial infarction. Now, what you have to remember is how to differentiate the tall T wave morphology of acute MI and tall T wave of your hyperkalemia. Tall T wave of hyperkalemia, it is tall tented T wave. Right? So this will be the T wave morphology in case of hyperkalemia. But in case of acute MI, if you take the tall T wave, this will be the tall T wave in case of acute MI. So in case of acute MI, you have broad, tall T wave. That is what you will have in case of acute MI. So now, apart from this tall T wave in this particular ECG, what are the other findings in favor of hyperkalemia? I will just summarize a slide with hyperkalemia and as well as the hypokalemia ECG changes. Now, if you take this particular ECG or if you take this slide here, in hyperkalemia, remember the earliest ECG change for hyperkalemia will be tall T wave. So the earliest ECG change in hyperkalemia will be tall T wave, and apart from that you take the ST segment depression will be there, and you take the QRS complex in patients with the hyperkalemia, you will have wide QRS complex, and you take the PR interval. The PR interval will be prolonged. Right? And you take the P wave, the amplitude of the P wave, right? The amplitude of the P wave, it will be flat or absent. Right? The amplitude of the P wave, it will be flat or absent. So these are the ECG changes in patients with hyperkalemia. Number one, the presence of tall T wave. Number two, ST segment depression. Number three, wide QRS complex. Number four, prolonged PR interval. Number five, the P wave becomes flat, right? Or it will be completely absent. These are the ECG changes in hyperkalemia. But you take in hypokalemia, please remember in hypokalemia, the earliest ECG change will be the appearance of the U wave. Right, the appearance of the U wave. So there will be a prominent U wave. That is one point. And subsequently, if you take the T wave, right? Subsequently, if you take the T wave, it is inverted or it will be flat. That is what you will see in case of the hypokalemia. And what are the other changes? There will be ST segment depression and there will be slightly PR prolongation, and you take the P wave, it will be peaked P wave. So this is exactly opposite to that of your hyperkalemia. So these are the differences between the ECG changes in hyperkalemia and as well as the hypokalemia. So going back to our clinical question. Now in this ECG strip, what all you are able to make out? Number one, tall T wave. Next, you take the QRS complex, you have the wide QRS complex, right? And you take the P wave, it is absent. Okay, so these are the hyperkalemia changes what you are having in this ECG. Now, how will you rule out the other ECG? Like for example, you take acute inferior wall MI. In acute inferior wall MI, what will be the ECG changes? This is the ECG of inferior wall MI. In inferior wall MI, you have ST segment elevation in 2-3 AVF. Right? There will be ST segment elevation in 2-3 AVF. That is what you will have in patients with the inferior wall MI. Okay. Now, one more option in our question was about the digoxin toxicity. In case of digoxin toxicity, what will be the ECG changes? In case of digoxin toxicity, the ECG changes will be in the form of ventricular bigeminy. Right, so ventricular bigeminy will be the most common ECG change in case of digoxin toxicity. Now, what are the other ECG changes like you will have in case of the digoxin toxicity? You can have all the types of arrhythmias, that is ventricular tachycardia and as well as ventricular fibrillation, and there can be also premature ventricular contractures. But please remember, the arrhythmias that you will not see in digoxin toxicity is atrial fibrillation. Right, arrhythmias not present in digoxin toxicity is atrial fibrillation, then atrial flutter and Mobitz type 2 AV block. Right, Mobitz type 2 AV block. So these are the arrhythmias that you won't see in case of digoxin toxicity. But remaining all, like you take ventricular bigeminy, ventricular tachycardia, ventricular fibrillation, premature ventricular contractures, all that can be seen in case of digoxin toxicity. So this was the clinical question related to your hyperkalemia, and I have also tried to explain about the other options as well. Now we will move on to the next important clinical scenario. Yes, so I have a ECG of a patient who is like 14-year-old female. She presents with an episode of palpitations and associated dizziness. And the ECG has been given to you here. And the options are paroxysmal supraventricular tachycardia, atrial fibrillation, Iotic stenosis, Wpw syndrome. Now, if you closely observe this particular ECG, what is that you are able to make out is like you take one individual complex. Right? You take one individual complex. What is that you are able to make out is you take the PR interval. The PR interval, it is short. When do you call short PR interval? When the PR interval, if it is less than 120 milliseconds, we call that as the short PR interval. So PR interval in this particular complex, it is short. And apart from that, you take the QRS complex in this individual. It is not the normal QRS complex. You are having the presence of wide QRS complex. When do you call wide QRS complex? When the duration of the QRS complex is more than 120 milliseconds, we call it as the wide QRS complex. And apart from that, if you can make out here, there is slurring of the R wave. Right, there is slurring of the R wave. So these three changes, short PR interval, wide QRS complex, slurring of R wave, all these together, where do you have? You will have that in patients with the Wpw syndrome. So in Wpw syndrome, the clinical presentation of the patient can be in the form of palpitations and as well as the dizziness. So what is this Wpw syndrome? It is a pre-excitation syndrome. right? It is a pre-excitation syndrome where the individual has the presence of an accessory bundle, right? And that particular accessory bundle, it is the bundle of Kent. And this particular accessory bundle, that is bundle of Kent, through this, the impulse will directly move from atria to ventricles without intervening AV node, right? So without intervening AV node, the impulse directly will move from SA node directly into the ventricle. That is why it is called a pre-excitation syndrome. And that is the reason why you have short PR interval. And that is the reason why you have wide QRS complex and you have the presence of the delta wave. So I was telling you that there is slurring of the R wave. Now the slurring of R wave is nothing but your delta wave. Right, so this is nothing but your delta wave. Okay, so this is about your Wpw syndrome. Now what about the other options? You take in case of PSVT. How will be the ECG of the PSVT? Remember, PSVT stands for paroxysmal supraventricular tachycardia, where the individual will have narrow complex tachycardia. I will just show you that ECG. Now this is the ECG of, yes, this is the ECG of the PSVT. So in case of PSVT, you have the presence of narrow complexes. Right? You have the presence of narrow complexes. Okay. So PSVT, it is a narrow complex tachycardia. And in case of PSVT, please remember, you don't have the visible P waves. Right? The P wave, it gets merged with the QRS complex, or the P wave, it will appear after the QRS complex. Right? You see here, it will appear after your QRS complex. And that particular wave is called pseudo R wave. That particular wave is called pseudo R wave. What is that? The P wave, whichever is appearing after the QRS complex, is called as the pseudo R wave in V1 and as well as V2. So this is how the ECG of paroxysmal supraventricular tachycardia will appear. And drug of choice for PSVT will be adenosine. So you need to give 6 milligrams of adenosine. Right, you need to give 6 milligrams of adenosine intravenously. And actually the first line treatment for PSVT will be carotid sinus massage. So carotid sinus massage will be the first line treatment. Right, that will be the first line treatment for your PSVT. Now, another options in our question was the atrial fibrillation. Let me just show you the ECG of atrial fibrillation also. So this is the ECG of the atrial fibrillation. See, what is that you are able to make out is, in atrial fibrillation, you will have irregular rhythm. So if you observe here, you don't have the RR interval being equal. So what is that you are able to make out? There is irregular RR interval. Right, there is irregular RR interval. So because of this irregular RR interval, what is that we need to assume? The heart rate, it is irregular rhythm. The rhythm is not regular rhythm, it is irregular rhythm. That is one important point in your atrial fibrillation. And the other important point in atrial fibrillation is there is no P wave. Right, there is no P wave. So whatever the waves you have is the fibrillatory waves. Right, whatever the waves you have is the fibrillatory waves. That is what you will see in patients with the atrial fibrillation. So how will you make out an ECG of atrial fibrillation? Number one, rhythm, irregular rhythm. Number two, absence of the P wave. Number three, the presence of your fibrillatory waves. Okay, so this is the ECG of atrial fibrillation. And you take one more option which was there in our question. The other option was the Iotic stenosis. See, in case of Iotic stenosis, what will be the ECG change? There will be presence of left ventricular hypertrophy. Because in Iotic Stenosis there will be increased afterload on the left ventricle and there will be left ventricular hypertrophy, and ECG will show you the features of left ventricular hypertrophy. Now, what are the features of left ventricular hypertrophy? In case of left ventricular hypertrophy, please remember the ECG should satisfy what is called Sokolov's-Lyon criteria. Right? It should satisfy what is called the Sokolov's-Lyon criteria. Now, what is this particular Sokolov's-Lyon criteria? It is nothing but SV1 plus RV6. If it is more than 35 mm, that is suggestive of left ventricular hypertrophy. Okay, you see here, this is your SV1, and you see here, this is your RV6. So SV1 plus RV6, it is more than 35 mm, that is nothing but your Sokolov-Lyon criteria, right? So this was the clinical question related to your Wpw syndrome, that is Wolff-Parkinson-White syndrome, which is a pre-excitation syndrome. Now you take one more clinical question. So if you see this ECG here, these ECG were taken from a 40-year-old male who presented with 60 minutes history of central chest pain. On arrival to the emergency department, he was pain-free. 4 minutes later, he developed further intense chest pain and a repeat ECG was performed. Now, which vessel do you feel that it is blocked in this particular patient? I will just show you this ECG in a zoomed manner. Right. So, carefully observe the ECG. What all the abnormalities you are able to make out? In this ECG, you are able to make out that there is presence of ST segment elevation in the lateral leads and as well as the anterior leads. I'll just show you that. So, this is your ST segment elevation in the anterior leads and as well as in the lateral leads. So, these are the lateral leads. So, 1 AVL, V5 and as well as V6. So in 1 AVL, V5, V6 and as well as V2, V3 and as well as V4. So in the anterolateral leads, right, in the anterolateral leads there is presence of ST segment elevation. So presence of ST segment elevation in the anterolateral leads. So it is suggestive of anterolateral MI, right? It is suggestive of the anterolateral myocardial infarction. Now, in case of the anterior wall, it is supplied by left anterior descending artery, and lateral wall, it is supplied by left circumflex artery. So, which vessel do you think it is blocked? It is left anterior descending artery and as well as the left circumflex artery, which is blocked in this particular patient. Okay. Now if it is only left anterior descending artery block, the ECG changes will be there only in the anterior leads. If it is only like left circumflex artery block, the ECG changes will be there only in the lateral leads. And if it is right coronary artery blockade, the ECG changes will be there only in the inferior wall. Right, that is in 2-3 AVF you will have ST segment elevation if it is right coronary artery blockade. Okay, so this is about the ECG related to anterolateral MI. Now we will take up one more clinical question. So if you take this clinical scenario, the following ECG is taken from 71-year-old man who presented with several episodes of ischemic sounding chest pain on a background of known ischemic heart disease. Already the individual is a known case of ischemic heart disease. Now he presented with the chest pain which is sounding similar to that of ischemic chest pain. Now what is the next step in the management of this patient? So this is the ECG of this particular patient. So you can observe what are the abnormalities. I'll just zoom this ECG for you. Right. So you can make out that there are some abnormal complexes within the rhythm strip. So you see this is an abnormal complex, right? And this is another abnormal complex. Now, what are these abnormal complexes? These abnormal complexes, right, they are broad QRS complexes. And if you take the morphology of this particular QRS complex, it is not similar to that of the normal QRS complex. It is wide QRS complex. And apart from that, you see the P wave. Do you have P wave? There is no P wave also for this particular QRS complex. So what does that mean? This means that it is a complex which is originating from the ventricle. So this is nothing but your ventricular premature contracture. Right, this is nothing but your ventricular premature contracture. So in case of ventricular premature contractures, you have the presence of the wide QRS complexes. Alright, now always remember, in an individual with an ischemic heart disease presenting to you with the history of ischemic pain and with the ECG showing the ventricular premature contractures, that is a sign that the individual may progress to land up in the myocardial infarction. So that is the reason why what is the next step in the management of this patient? You need to admit the patient and you need to do serial ECGs and compare the ECGs with the previous ECGs. This is not an acute MI, right? He may progress into acute MI. So that is the reason why you admit the patient and then you need to do the serial ECGs within the individual. When do you require thrombolysis and as well as percutaneous coronary intervention? You require thrombolysis and percutaneous coronary intervention only when the individual has developed acute myocardial infarction, which is not in this particular case. Okay, and you take the fourth option, ignore, because they are the artifacts. So please remember, they are not the artifacts. So what are they? They are your ventricular premature contractures. Okay, right. So the answer to this question is you need to do the serial ECGs and comparison with the prior ECGs. Okay, now we will take up the next question. Following are the features of raised intracranial pressure that is associated with the ECG changes except. Options are widespread giant T wave inversions, QT shortening, bradycardia, ST segment elevation or depression. Now raised intracranial pressure, remember, there will be activation of a reflex and that particular reflex is nothing but the Bain bridge reflex, or we also call it as Cushing's reflex. Right, there will be activation of the Cushing's reflex. So once there is activation of the Cushing's reflex, the individual will have bradycardia. So bradycardia is one of the ECG change in case of raised intracranial pressure. Now apart from that, in raised intracranial pressure, if you take the ECGs, you will have the ECG with giant T wave inversion and that is called as cerebral T waves. So in case of cerebral T waves, you have T wave inversions of this morphology, right? Giant T wave inversions. And next thing is there can be ST segment elevation or the ST segment depression. But what about the QT interval? The QT interval is not shortened. The QT interval will be prolonged in patients with the raised intracranial pressure. Right? QT interval will be prolonged. It is not QT interval shortening. So the question asked is the except. Now let me just show you the ECG of the patient with raised intracranial pressure. Now what would be the cause for raised intracranial pressure? Like for example, you take subarachnoid hemorrhage, or for example, you take cerebrovascular accident, or for example, you take intracranial space occupying lesion. See, in all these conditions, there will be raised intracranial pressure. So wherever you have raised intracranial pressure, please remember what will be the ECG changes? Giant T wave inversion. These are called cerebral T waves. Right, these are called cerebral T waves. And you take ST segment. ST segment, either it is depressed or it is elevated, and you take the QT interval. The QT interval will be prolonged. right? The QT interval will be prolonged. The QT interval will not be shortened here. The QT interval will be prolonged. So these are the ECG changes in case of the raised intracranial pressure. Alright. Now we will move on to the next question. Right. So this is another important clinical scenario. That is, I have a 35-year-old male who presented to the emergency department complaining of palpitations, dyspnea, lightheadedness for the preceding hour. He has no known past medical history. Vital signs shows blood pressure of 115 by 65 millimeters of mercury, respiratory rate is 20 per minute, and saturation 98% on room air. And temperature of the individual is 36.6 degrees centigrade. And ECG is shown, and what is the diagnosis? And the options given to you are SVT with aberrancy, atrial fibrillation with Wpw syndrome, polymorphic ventricular tachycardia, and then the ventricular fibrillation. Now I will just zoom this ECG for you and then we will discuss this ECG. So you observe this ECG here. Yes. So if you observe this ECG, what is that you are able to make out? First and foremost, there is wide QRS complexes, right? And the second important thing, if you observe, the RR interval is not regular. It is irregularly irregular RR interval. That means how is the rhythm? Rhythm is the irregular rhythm. So wide QRS complexes you have, irregularly irregular rhythm you have, and you observe the PR interval also. The PR interval, it is short, right? The PR interval, it is short. I'll just make out all the ECG changes. Number one, irregularly irregular rhythm. Okay, how is that you are able to tell that it is an irregularly irregular rhythm? Varying RR interval, right? Varying RR interval, that is one point. So irregularly irregular rhythm, where do you have? You will have that in patients with the atrial fibrillation. Okay, we will keep it aside. That is one point. And second point is, you take the QRS complexes. You have the wide QRS complexes, right? You have the wide QRS complexes. And the next important point here is the PR interval. If you take, right, it is a very short PR interval, right? If you take the PR interval, it is like very short PR interval. That is what you will observe. Okay, short PR interval. Right, short PR interval. And the next important point apart from the short PR interval is that in the QRS complex, if you observe, there is slurring of the R wave, right? There is slurring of the R wave, and this is nothing but your delta wave. Right, this is nothing but your delta wave. So this is what is nothing but atrial fibrillation with Wpw syndrome. So now how will you rule out the other options? I will tell you. But the points in favor of atrial fibrillation with Wpw syndrome is irregularly irregular rhythm and wide QRS complex, short PR interval, and as well as the presence of the delta wave. Now you take the other options like SVT with aberrancy. In case of, what is SVT with aberrancy? It is supraventricular tachycardia with aberrancy. That means in case of SVT with aberrancy, there should be features of bundle branch block. And this bundle branch block, either it would be left bundle branch block pattern or it would be right bundle branch block pattern. Right, it should be either right or left bundle branch block pattern. But in SVT with aberrancy also, you will have wide QRS complex. Why? Because there is bundle branch block. Right, because there is bundle branch block, you should have the wide QRS complex. Okay, that is an important point that you need to remember. Now, let me just zoom this ECG and just show you. Now, you take V1, right? So this is your V1 and you take at the same time V6. If you observe the QRS complex in V1 and as well as V6, it is the QRS complexes suggestive of bundle branch block. Now, which particular bundle branch block? Is it right bundle branch block or is it left bundle branch block? Let me explain you. In V1, right, in V1, whatever you are observing here, right, whatever you are observing here, it is a pattern of RSR dash pattern, right, that is M pattern. The presence of M-shaped R wave in V1, right, presence of M-shaped R wave in V1, that is suggestive of right bundle branch block, right, that is suggestive of right bundle branch block pattern. For suppose in V1 if you have W-shaped S wave, right, in V1 if you have W-shaped S wave, then this is suggestive of left bundle branch block pattern. Now to summarize this ECG, what is that you will tell me now? It is SVT with aberrancy with right bundle branch block pattern. Why it is right bundle branch block pattern? Because you have RSR dash pattern in your lead V1, which is nothing but your RBBB pattern. So this is how the ECG of SVT with aberrancy will be. And another point which is going against your atrial fibrillation with Wpw syndrome. In SVT with aberrancy, you will have a regular rhythm. Right? In the previous ECG, right? In the previous ECG, what did I tell you? In the previous ECG, if you observe here, you have irregular rhythm. That is the point which is going against your SVT with aberrancy. Now, what about the other two options? That is polymorphic ventricular tachycardia and as well as ventricular fibrillation. In polymorphic ventricular tachycardia and ventricular fibrillation, you have the regular rhythm, but it will be of ventricular complexes. Let me just show you even that particular ECGs of the polymorphic ventricular tachycardia. Right. This is the ECG of polymorphic ventricular tachycardia. The word itself tells you polymorphic. What do you mean by the word? Polymorphic means you have the Qrs complexes, right? You have the Qrs complexes of variable morphologies. Right? You have the Qrs complexes of the variable morphologies. That is what is called as the polymorphic ventricular tachycardia. Now, in case of polymorphic ventricular tachycardia, remember the rhythm, it is regularly maintained, but it is a ventricular rhythm. Okay, I'll just zoom this ECG for you so you can make out the complexes. The ventricular complexes, whatever you are observing here, it is of not same morphology. They are of variable morphology. And the last one is your ventricular fibrillation. See, ventricular fibrillation, this is how the ECG will be. You don't have an identifiable QRS complex. Right? You don't have the identifiable QRS complex in case of the ventricular fibrillation. And these patients with ventricular fibrillation, the treatment of choice will be DC shock. Right? The treatment of choice will be DC shock. Right? You need to give 200 joules of unsynchronized shock. Then only the individual can revert back. So these are the clinical ECGs related to this question. So our question was actually on atrial fibrillation with Wpw syndrome. But I have tried to show you the ECGs of all other options as well. Now, let me just show you one more ECG, clinical ECG. Right. If you see this question, we have a 69-year-old male who had a dual chamber pacemaker inserted earlier in the day. He complained to the ward staff of pain at the insertion site and you have been asked to review him. His blood pressure, temperature, saturation, respiratory rate, all are within the normal limits. Right? All are within the normal limits. An ECG is performed and it is as follows. What is the correct answer? Properly placed pacemaker leads misplaced, patient developed acute MI, normal ECG. Right. Now you zoom this properly and then observe. Right. So mainly you need to concentrate your vision on lead V1. Right. You need to mainly concentrate your vision on lead V1 and as well as the lead V6. So this is your V6. Now properly observe what is that. Okay. First I'll just give you the answer, then I will give you the explanation as well. The answer to this question is, in this patient the leads are misplaced. So how can you tell that the leads are misplaced in this patient? The patient had a dual chamber pacemaker and patient had complaint of pain at the insertion site and repeat ECG was done and repeat ECG shows the following. Okay. Now this is a ECG of leads misplaced. So how to make out that it is the ECG of leads misplaced? First of all, I will just tell you how will be the normal ECG with a pacemaker. Now whenever you are keeping a pacemaker, where will you place the leads? If it is a dual chamber pacemaker, in case of dual chamber pacemaker, please remember one lead is placed in the right atrium and the other lead is placed in the right ventricle. That is where the leads are placed in case of the dual chamber pacemaker. For one lead in the right atrium and the other lead in the right ventricle. Now, the lead whatever you have placed in the right ventricle, what it will do? It will activate the right ventricle first. Right? It will activate the right ventricle first. Okay. Now, after the right ventricular contraction, then there will be subsequent left ventricular contraction. Right, then there will be subsequent left ventricular contraction. So initially right ventricular contraction first, then subsequently left ventricular contraction later. That is what should happen normally. That is what should happen normally. Now when the right ventricle is contracting first and subsequently left ventricle is contracting later, how should be the ECG? The ECG should have left bundle branch block morphology. Right? Why ECG should have left bundle branch block morphology? Because right ventricle is contracting first and later on the left ventricle is contracting. The same thing will happen in LBBB ECG also. In left bundle branch block also, the right ventricle will contract first, then followed by that left ventricle will contract later in the ECG of the left bundle branch block morphology. Now, if at all, if the ECG has to show left bundle branch block morphology, how should be the Qrs complexes in V1 and as well as V6? In LBBB morphology, in lead V1, you should have W-shaped S wave. Right? You should have W-shaped S wave. And in LBBB ECG, V6, it should show M-shaped R wave. Right? It should show the presence of M-shaped R wave in V6. That is what should happen in the left bundle branch block ECG. Right? In LBBB ECG, this should be the normal thing. You should have W-shaped S wave in V1 and M-shaped R wave in V6. This is the ECG pattern that should be there if the patient is on dual chamber pacemaker. Right? If the patient is on dual chamber pacemaker, this should be the ECG pattern. But you see our ECG, how is it? Right? Now if you observe our ECG, you take lead V1. Right? See, this is your lead V1. How is this lead V1? It is showing you M-shaped R wave. Right? It is showing you the presence of M-shaped R wave in V1. So, the presence of M-shaped R wave in V1, what is this suggestive of? This is suggestive of right bundle branch block pattern. So that means the lead which has to be placed in the right ventricle has misplaced into the left ventricle, and that is the reason why you are having the right bundle branch block morphology. So this is the ECG of the misplaced leads, right? This is the ECG of misplaced leads, because if you are having RBBB morphology, what does that mean? That means that left ventricle is contracting first, then followed by that right ventricle is contracting. That is what is nothing but the meaning of the right bundle branch block. In dual chamber pacemaker, what should happen? It is exactly reverse. Right ventricle should contract first, then followed by that left ventricle should contract, and the ECG should show you the left bundle branch block morphology. Okay, so in this patient the leads are misplaced, right? In this patient the leads are misplaced. And another important point to tell you that this is the ECG of a pacemaker is, you have a vertical line just beneath, before the QRS complex. You can observe one vertical line, one small vertical line you can observe before each and every QRS complex. That is the pacemaker rhythm which is originating within the right atrium. So the presence of small vertical line before the QRS complex tells you that the patient is on the pacemaker. Alright. Now, after having discussed about this particular clinical ECG, we will move on to the next one. So, if you take the other clinical scenario, we have 84-year-old male complaining of the general lethargy, nausea, and there is also several episodes of diarrhea, dizziness. Past history of atrial fibrillation, diabetes mellitus, hypertension is present. Medications include aspirin, ACE inhibitor, statin, sulfonylurea, and digoxin. He is conscious, vague but oriented, and his blood pressure is 112 systolic blood pressure, and ECG is given to you here. The options are first degree AV block, Mobitz type 1 AV block, Mobitz type 2 AV block, and then the complete heart block. So you observe the ECG here. I'll just zoom this for you. So you can make out that the P wave and QRS complexes, there is no correlation. You have the P wave, right? You have the P wave on its own, and the QRS complexes, they are present on its own. There is no coordination. Right? There is no coordination between the P wave and the QRS complex. So what is this called then? When there is no coordination between the P wave and the QRS complex, that means that atria is beating on its own, ventricle is beating on its own. This is a case of complete AV block. Right, this is a case of complete atrioventricular block, which is nothing but third degree heart block. Right, which is nothing but it is your third degree heart block. Whereas how will be the ECG changes in the other options? You take in first degree heart block. In case of first degree heart block, there will be association between atrial and as well as ventricular contractures, but in case of first degree heart block, you will have only prolonged PR interval. That will be the ECG change in the first degree heart block. And you take in case of Mobitz type 1. Mobitz type 1 AV block, which is nothing but your Wenckebach's phenomenon. So in case of Mobitz type 1, which is nothing but Wenckebach's phenomenon, there will be progressive prolongation of the PR interval, right? There will be progressive prolongation of the PR interval, and there will be subsequent drop in the QRS complex. Right, subsequently there will be drop in the QRS complex, and again you will have the ECGs with PR interval being progressed. And in case of Morbid's type 2, you will have a constant PR interval. Right, you have a constant PR interval, but there is intermittent drop in the QRS complex. Right, but there is intermittent drop in the QRS complex. That is what you will observe in case of Morbid's type 2 AV block. Okay, so this is the ECG of the various, all the options which are given in your clinical scenario.